Imagine executing what looks like just a flawless thigh excision.
Right.
You navigate the planes perfectly, you get a beautiful closure, and the patient goes home happy.
Sounds like the dream scenario.
Yeah, exactly.
Well,
But then, 3 months later, that same patient comes back to your clinic with severe permanent labial spreading.
oh, yeah.
It is an absolute functional and aesthetic disaster. And the truly terrifying part of this.
It's that you probably missed just one single anchoring point.
Exactly. One invisible fascial anchor during the anterior closure. So look, you are preparing for the FRCS plastic surgery board exams right now.
Yep.
The timeline is shrinking, the pressure is really mounting, and you need to somehow synthesize this overwhelming mountain of dense anatomical and surgical data.
Which is not easy.
Not at all. So welcome to this rapid-fire, high-yield deep dive. We have exactly one mission today, and that is to equip you with the critical, non-negotiable facts for brachioplasty and thigh lift contouring procedures.
Right, because the examiners, they aren't looking for generalities. They don't want to hear you just, guess your way through a procedure.
No fluff today.
Exactly. They want to see if you genuinely understand the precise biomechanics. Like, do you actually know the anatomical planes? Do you know how the tissues behave under tension?
Right.
Because it's those specific fascial anchoring points that separate a totally safe, durable procedure from a catastrophic complication.
Yeah, a complication you absolutely cannot afford. So before we make our first incision into this material, I have a direct instruction for you.
What's up?
Head over to medicinclimited.com right now and get the FRCS Plastic Surgery Anki Deck.
It's an absolute game changer.
It really is. It
Yeah.
features over 6,000 questions arranged meticulously by topic to help you instantly recall these exact key facts. And it is based entirely on the textbook Keynotes in Plastic Surgery.
Yeah, if you're serious about passing these exams, you need that resource.
100%. Also hit the follow button on your app so you hear more of these targeted deep dives. And rate the show if you learned something valuable today. Let's just get straight to work.
Let's do it. We're sticking to a strict question and explanation format today to really maximize your recall.
Rapid fire.
Exactly. We'll look at the preoperative planning phase, the actual execution on the table, and most importantly, the anatomical rationale dictating every single move your scalpel makes.
So let's start with the upper extremities, brachioplasty.
Good place to start.
The primary goal here is treating skin laxity of the upper arms. Now, when a patient comes in with that classic batwing deformity,
Or the Malaysian flying squirrel appearance, as it's sometimes called.
right, yeah. A junior resident's very first instinct might just be to grab a cannula and aggressively use liposuction to remove all that bulk. Why is that instinct a fundamental misunderstanding of the actual pathology?
Well, it's a misunderstanding because you really have to recognize which tissue layer is failing. Brachioplasty is fundamentally a skin operation. It's designed to treat skin laxity and a complete loss of elasticity. It is not, strictly speaking, a fat excision operation.
Right. It's not just about volume.
Exactly. I mean, you can combine excision with liposuction as a helpful adjunct to thin the flap.
Sure.
But if you only do liposuction on someone with significant skin laxity, you just deflate the arm.
Like letting the air out of a balloon.
Yeah, the skin won't miraculously recoil. You'll just be left with this hollowed out, hanging sleeve of empty tissue.
Which honestly might look worse than what they started with.
It arguably is worse.
Yeah.
You absolutely must excise the redundant skin.
That makes perfect sense. Okay, so we know we have to cut. Let's get into the preoperative markings, because this is heavily, heavily tested on the FRCS.
Extremely testable, yes.
What is the precise patient position required, and how exactly do we establish the axis for our markings?
So the markings dictate the entire geometry of the operation. The patient absolutely must be marked in an upright position,
Standing or sitting?
either standing or sitting, but they must be upright. And their arm must be abducted to exactly 90 degrees.
Okay, 90 degrees.
Right. And your aim here is to plan and excise an ellipse, or, well, a modified ellipse, in a very specific orientation. Because the goal is that once it's completely healed, the resting scar sits precisely on the posteromedial aspect of the arm.
I really want to focus on that axis of excision for a second. What exact anatomical landmarks are we using here? I mean, why not just pinch the skin wherever it feels the loosest and draw a line?
Because you need predictability, and you need to hide that scar.
Right.
The axis must be marked strictly between two defined points. Point 1 is the midpoint between the olecranon and the medial epicondyle at the elbow.
Olecranon and medial epicondyle midpoint. Got it.
And point 2 is the proximal extent of the excess skin. Now, that proximal point must strictly align with the posterior axillary fold.
Okay, so a line connecting those two.
Yes, by defining your axis along that specific line, you ensure the scar is hidden on the posteromedial arm,
So it's out of sight from the front.
out of sight from the anterior view, and largely out of sight from a direct posterior view when their arms are resting at their sides.
Are there any alternatives to that specific placement?
Yeah. Alternatively, the scar can be planned to lie within the bicipital sulcus on the medial arm, but that olecranon medial epicondyle midpoint is the highly tested standard.
Here is where it gets really interesting and honestly a bit counterintuitive when you're first learning this. You're meticulously marking this upright patient with their arm at 90 degrees.
Right.
But the surgery itself is done completely supine. It feels exactly like a tailor pinning a bespoke suit on a client while they're standing up.
That's actually a great analogy.
Right, because if the tailor tries to pin it while the client is lying flat on the floor, the suit is going to fit terribly the second they stand up.
Yeah.
Gravity dictates the true drape of the tissue.
Yeah, take that tailor analogy even further. If they don't account for how the fabric stretches and hangs under gravity, the final garment restricts movement.
Yeah.
Or it just sags entirely.
Which is exactly what happens to the arm skin.
Precisely. Gravity distorts that lax tissue inferiorly when they stand. If you try to draw your ellipse while they're supined, the tissue falls posteriorly and just spreads out.
So you misjudge the laxity entirely.
You'll inevitably misjudge it. You end up with either a severe under-resection or your final scar migrates anteriorly and becomes supervisible. You have to capture the reality of gravity during marking.
Okay, so we have the standard ellipse marked. But clinically, and on the boards, these modifications often need to address the lateral chest wall and the axilla.
Very common.
How do we handle severe axillary excess? Like if that bat wing doesn't stop at the armpit but extends way down the chest wall?
In those cases, a simple arm ellipse leaves a massive dog ear and completely ignored the chest laxity.
Right.
So you have to transition to what's known as a fish incision brachioplasty.
A fish incision?
Yeah, you excise a second ellipse positioned at exactly 90 degrees to your primary arm ellipse.
Got it. So they intersect.
Exactly. You're creating an intersection to manage the multidirectional tension vectors of the axillary dome.
And what are the specific variations of this that examiners might ask about?
You need to recognize the L brachioplasty,
Yeah.
the W brachioplasty, and the quadrangular flap brachioplasty.
Okay, L, W, and quadrangular flap.
Right. They all essentially do the same thing, breaking up the incision to handle that multidirectional excess without causing severe bowstring contractures.
Right, markings are locked in. Now we move from the marking room to the OR table. The patient is supine, arms abducted on boards.
Yep.
We do liposuction first if we planned for it, then we make the anterior incision. Here is the critical procedural question. The surgical undermining has to stay strictly superficial to the deep fascia.
Absolutely.
It sounds easy, but slipping out of that plane is devastating.
Yeah.
What exactly are we actively protecting in this specific plane?
Two highly vital structures. First, the primary lymphatic channels of the upper extremity.
Okay, lymphatics.
If you carelessly dive deep to the fascia and disrupt those, the patient gets severe postoperative edema or intractable seromas.
And what's the second structure? The nerve, right?
Yes, highly testable. The medial cutaneous nerve of the forearm. It is extremely vulnerable right there.
So if you stray deep.
If you stray deep and transect it, or even just put severe traction on it, you leave the patient with a permanent, debilitating sensory deficit. That deep fascial boundary is an absolute no-go zone.
So we stay superficial to the deep fascia. Now, before we make the posterior incision to complete the excision, standard practice says we must castellate and tailor tack the skin flap.
You have to.
But I want to push back on this just to really clarify the mechanics. If a surgeon drew a perfect ellipse upright, factoring in gravity, why not just boldly cut both sides of the drawn ellipse and remove the whole block at once?
Because you are begging for severe tension mismatches if you do that.
Even with perfect markings.
Even with flawless upright markings, you have to account for the fact that tissue elasticity varies wildly across the arm.
Ah, okay.
And the biomechanics change the absolute second you make that first anterior incision
Right.
and release the tension on that side.
Right. The tissue behaves totally differently once it's freed up.
Exactly. Castellation and tailor tacking act as a mandatory physical trial run. You temporarily staple or suture the edges together to definitively confirm the closure is tension-free and symmetric.
Before you commit to the final cut.
Right, before that irreversible posterior cut, it ensures accurate real-time tailoring based on how the tissue actually behaves on the table.
That makes perfect sense. So we remove the excision block, And we move to closure. The strict rule is closure must run from distal to proximal. Why?
You close from distal to proximal, specifically to avoid leaving a dog ear at the elbow.
Because the elbow is so visible.
It's highly visible and functionally dynamic.
Right.
A bulky dog ear there is aesthetically terrible and prone to breaking down.
So by starting at the elbow,
By starting distally at the elbow and working proximally toward the axilla, you actively push any excess tissue or length discrepancies toward the armpit.
where it's hidden.
Exactly. The axilla is a hidden concavity where that excess can just be tailored out or hidden in the natural fold.
Speaking of the axilla, how do we recreate that natural concavity? We just removed a massive amount of tissue. A straight line closure across that joint is a recipe for a bowstring contracture.
Yeah, a straight scar will inevitably contract and limit range of motion, so you prevent bowstringing by strategically using Z-plasties.
Okay, Z-plasties to break it up.
Right. It physically breaks up the straight line scar, lengthens it, and recreates the recessed dome of the axilla.
Does that handle all the tension?
It does it so well that it may actually obviate the need for a formal SFS suspension. That's the Scarpa's fascial system suspension between the upper arm flaps and axillary fascia.
Oh, wow. So you might not even need Lockwood's SFS suspension if your Z-plasty is good enough.
Exactly. Historically, Lockwood advocated for it heavily, but the geometry of a well-executed Z-plasty handles that tension distribution beautifully on its own.
Incredible. Okay, let's pivot our focus completely. If upper extremity contouring is a battle of tension, lower extremity contouring is an all-out war against gravity.
Unforgiving gravity, yes.
We're moving to thigh lifts. Gravitational forces on that sheer mass of tissue make fascial anchoring exponentially more critical.
Without a doubt.
So, skin laxity dictates the procedure. Proximal laxity gets a proximal lift. But if it extends down to the knee, we need an extended vertical lift. Let's start with the proximal lift. Just like the arms, marked standing right.
Always marked standing. You rely on that position to accurately gauge the heavy drop of the thigh tissue.
Walk us through exactly where these excision lines fall.
Let's trace the superior excision line first. You mark this exactly midway between the labia majora or scrotum in males and the thigh.
Midway. Okay.
From that midpoint, it continues anteriorly, where it can actually join an abdominoplasty scar if you're doing a combined case.
Makes sense. And posteriorly.
Posteriorly, it curves laterally, wrapping precisely around the ischial tuberosity, and then settles seamlessly into the natural gluteal crease.
All right, so that curve around the ischial tuberosity is our definitive upper boundary. How do we determine the lower boundary? How do we measure the max width we're removing?
You find the maximum width on the medial thigh, specifically in the mid-axial line.
And how do we estimate the width?
You do a physical skin pinch test. But importantly for the exams, the patient's hip absolutely must be flexed and adducted during this pinch.
Wait, flexed and adducted, why?
Because you have to simulate the maximum tension the closure will experience when they are sitting or walking.
Of course. If you pinch with the legs straight.
It'll be disastrously tight the second they try to sit down or take a step.
Got it.
So once you have that maximum width point with the hip flexed and adducted, you draw a crescent-shaped extension sweeping up to join your superior mark at the mons pubis anteriorly and the gluteal fold posteriorly.
I do want to interject with a practical caveat. Standing is the absolute gold standard to account for gravity. But what about extreme clinical realities? Like a massive weight loss bariatric patient with unwieldy skin excess.
Right.
Marking them standing might be physically impossible because the tissue folds just obliterate all your visual landmarks.
Yeah, that's a very astute clinical distinction. While standing is the inviolable rule generally, massive skin folds can hide everything you need to see.
So what do you do?
In those extreme scenarios, supine marking becomes a necessary fallback just to ensure surgical safety. You trade the benefit of seeing the gravitational pull for the sheer necessity of actually seeing the anatomy.
Okay, let's build on those proximal markings. What if the deflation stretches all the way down the leg to the knee?
Then you need the extended or vertical thigh lift.
Often called the L-thigh-plasty, right?
Exactly, because the proximal transverse scar and the vertical scar form an L.
Marking this vertical component requires putting the tissue under active traction. How exactly do we do that?
You manually hold the thigh skin under strong supromedial traction.
Upward and inward.
Right, mimicking the final lifted vector. While holding that traction, you mark the anterior excision line starting from the medial knee straight up to intersect the widest point of your proximal transverse excision.
That's the anterior line. How do we find the posterior line while fighting all that mass?
Another skin pinch test, this time at the mid-thigh level. Mark that pinch point. Then extrapolate a line upwards toward the ischial tuberosity and taper it downwards toward the knee to meet your anterior line.
The holy grail here is leaving that healed vertical scar hidden perfectly in the mid-axial line of the medial thigh, right? So it's not visible front or back.
That's the goal.
But let's be realistic. What if the patient has profound laxity extending clearly below the knee joint? Do we arbitrarily stop the excision at the knee to save the scar placement?
No, absolutely not. The pathology must dictate the procedure. If the laxity goes below the knee, you have to extend the excision inferiorly, dropping below the joint line.
The Carney.
The cosmetic trade-off is significant. You have to thoroughly counsel the patient because once it crosses the knee, that scar becomes highly unavoidably visible. You lose all natural camouflage.
We have our geometry set. Let's move to the procedural execution. This is where examiners will mercilessly test your fascial anchoring knowledge.
Oh yeah, they will dig into this.
We actually start prone, hips slightly abducted. We make the gluteal crease incision, undermine superficial to deep muscle fascia. Why is it mandatory to preserve the soft tissue padding over the ischial tuberosity? And how do we manage the posterior SFS?
You must preserve that padding over the ischial tuberosity to prevent severe seating pain and to physically protect the bone from pressure sores. You never strip that bone bare.
Okay, leave the pad.
Always. Now, the golden rule before making your inferior incision, you never make it until you physically confirm a tension-free closure is possible.
Non-negotiable safety step.
Completely non-negotiable.
Right.
Once confirmed, you must take the posterior SFS, the Scarpa's fascial system, and meticulously resuspend it to the ischial periosteum using heavy permanent sutures. That mechanically anchors the entire posterior lift.
So posterior is anchored to the ischial periosteum. When we flip the patient supine and do the anterior part, let's use a bridge analogy.
Okay.
If you anchor a heavy suspension bridge into loose topsoil instead of bedrock, the whole structure drags down under its own weight. We need bedrock for the anterior thigh.
Yes, we do.
What is the precise anchoring point for the anterior thigh SFS? And what happens if you fail?
Your bedrock anteriorly is callus fascia. The anterior thigh SFS must be strongly resuspended to callus fascia, which is anatomically continuous with it, or directly to the pubic periosteum.
And if a surgeon misses that step?
If you fail to anchor it, the massive shear weight and gravitational pull of the thigh tissue causes severe downward tissue descent.
Which leads us back to our nightmare opening.
Exactly. It pulls directly on the genitalia, causing that severe permanent labial spreading. It's a devastating complication, completely preventable if you just respect that fascial suspension.
Such a crucial takeaway. Before we finish, I want to bring up the extended thigh lift again. The designated plane for the vertical portion is deep to the SFS, but superficial to the great saphenous vein.
Which is an incredibly tight corridor.
Right. You're sandwiched between a fascial system and a massive venous structure, trying to preserve delicate lymphatics so you don't cause debilitating lymphedema. How do you safely navigate that? Is there a safer modification?
Because the risk profile is so astronomically high in that plane, many surgeons strongly advocate for a lipo-assisted skin excision.
Lipo-assisted. How does that change things?
Instead of a direct en-bloc surgical excision in that dangerous plane, you first do aggressive, targeted liposuction in the exact area of the planned vertical excision.
So you remove the fat bulk first.
Right, but crucially, it leaves the intricate lymphatic network largely intact within the fiber septa. After the lipo, you do a sharp excision of the skin only.
Oh,
By preserving that deeper subcutaneous matrix, you drastically improve lymphatic preservation while still removing the redundant envelope.
wow, that makes a lot of sense. So what does this all mean for you listening as you mentally prepare for these board exams?
You've got a lot of mechanics to remember.
You deeply understand the exact pre-op markings, the protective planes, and the critical fascial anchoring points to prevent tissue descent. But I want to leave you with a theoretical question to mull over.
A little extra homework.
Right. You know how to suspend the anterior SFS to callus fascia to prevent labial spreading. But consider your patient population. Think about how the significantly altered, mechanically attenuated fascial integrity in a massive weight loss patient might dictate the long-term failure rate of these SFS suspensions.
That's a great point, compared to standard age-related laxity.
Exactly. The core anatomy is the same, but the microscopic tissue quality and tensile strength are entirely different. How does that biological reality change the true durability of those heavy suture anchors over a 5 or 10-year period?
Something they definitely need to think about.
Keep that complex biomechanical concept in mind as you continue studying. Before we sign off, here's your final reminder. Do not leave your board prep to chance.
Now get the deck.
Head straight to medsynclimited.com right now to secure the FRCS Plastic Surgery Anki Deck. With over 6,000 topic-arranged questions based directly on the textbook Keynotes in Plastic Surgery, it is unequivocally the best way to lock in these high-yield facts.
Wow.
Hit the follow button on this deep dive so you don't miss our next breakdown, and rate the show if it helped clarify these complex concepts for you. Please leave a comment or question below regarding any of the anatomical planes or forces we covered today. Until next time.